Okay. As we move towards our next speaker, she has arrived on um, to the platform, and I'm just want to introduce myself really quickly. I'm Allison Evans. I have been a nutrition support dietitian, I think, since 1996. I don't know. We're all getting to be the seniors around here. But and I worked 15 years in the hospital and now in home infusion. And I'm the incoming, what am I, president-elect for Gaspin. And I am very involved with Aspen, which is just a fantastic organization all around. It has impacted my career in so many ways and my practice. So if you're not engaged in any Aspen activities, they are a very welcoming society, and you will learn so much and have so many peers to connect with. So it really just grows your career in ways I cannot describe here. And I just choked on my saliva. Um, so I'm very, let me just get a glass of. But it is a great privilege to have Dr. Dickey here today to speak to us about um, short bowel syndrome, enterocutaneous fistulas, and intestinal failure. Dr. Dickey is an advanced practice provider at Emory Healthcare with general and GI surgery. She has worked with Dr. John Galloway treating short bowel, ECFs, and intestinal failure patients for the past 5 years. Prior to coming to Emory, Dr. Dickey worked in trauma and emergency general surgery for 16 years. Ooh. Oops. She has a Bachelor of Arts in Psychology from Emory University and a Bachelor of Science in Nursing from Kennesaw State University. She is a board certified adult gerontology critical care nurse practitioner. And Dr. Dickey graduated in December with her doctorate in nursing practice for quality improvement and leadership from the University of Alabama, Birmingham. Congratulations, Dr. Dickey. She is married with 3 adult children. In her free time, she enjoys watching college football, Go Dogs, and Roll Tide, so a split house, and hiking with her Cavalier King Charles Spaniel named Lady. So I'm very excited to have you, Dr. Dickey, and we will turn it over to you.
Hello, thank you so much for having me today. Let's see, where do we put the water? I'm just going to set it.
Yes.
That works. All right. Well, I will try and make this entertaining. We're going to talk about poop. Just going to be honest, it's a little bit of a lighter topic. Okay. And for disclosures, I have no conflicts of interest related to this presentation. I did do this same exact presentation at the Virginia Aspen Conference up in May. Learning objectives for today, there will be 3. One, we're going to define short bowel syndrome, differentiate the anatomical short bowel syndrome and the physiological short bowel syndrome. Manage patients with short bowel syndrome based on intestinal length, presence versus absence of the ileocecal valve, and colon continuity. And then we're also going to identify complications of short bowel syndrome and treatment, and then describe the prognosis for the short bowel syndrome in the context of a small bowel transplant. So first, to kind of general knowledge, adults have on average about 850 centimeters of small bowel. That's about 27.8 feet. Short bowel syndrome in adults is defined as having less than 200 centimeters of remaining small bowel, which is about 6.5 feet. And that does not count for colon that they would have. Adults have approximately 150 centimeters of colon, which is about 4.9 feet. This is an illustration that is in Carol Parrish's book, what we like to call the Blue Short Bowel book. I'm sure most all of y'all are very familiar. I have found great success with patients being able to understand kind of what their anatomy is with this visual image that's in the book, kind of simplifies it from that standpoint. So, anatomy and physiology of the bowel. First, the primary role of small bowel is to break down and absorb nutrients and then pass it into the blood system. Okay. The duodenum breaks down ingested food and digestive enzymes from the liver, gallbladder, and pancreas. The primary role of the colon is to absorb water, electrolytes, water-soluble vitamins, and help form stool. And the ileocecal valve controls the digested food in the small bowel entry into the colon. I often tell my patients that that is the doorway from the small bowel to the colon, and not having your ileocecal valve can really be an impactful thing on a lot of these patients, no matter if they're short bowel or not. Anatomy here just kind of gives you a brief illustration of the location where the liver and the gallbladder and the stomach, pancreas, with the intestines and the colon. Now, how do patients become short bowel? Commonly, it can be a result of multiple abdominal surgeries that require small bowel resections. The most common cause in children is necrotizing enterocolitis. They can have a volvulus, intestinal malformations, and then injury that would require small bowel resection, as in trauma. Common causes in adults: Crohn's disease is a big one. Mesenteric ischemia, meaning that the mesentery that it provides the blood flow to the small intestines doesn't, it like ceases, and then you have a huge section of small bowel that dies off because of it. Radiation enteritis is another one. People that have had cancer and had radiation, typically about 10 years after they finish their radiation, we will start noticing these folks coming in. They'll be having small bowel resections. They have very difficult abdomens to get into. When we go in, usually everything is pretty hard in that area of trying to dissect through it. They end up high risk of fistulas when we go in, and unfortunately can be short bowel and more bowel obstructions. Injury, again, trauma, MVC, ground level fall. Cancer is another one. And then post-surgical adhesions. That is one where some people have what we call adhesive disease. So anytime you have surgery on your abdomen, you're going to form scar tissue. That's how your abdomen heals. Some people kind of overheal over time, will make extra scar tissue. So, and it's not something that you can readily see on imaging. It's actually once we get into the operating room and we're doing surgery that we see it. I described these adhesions. Everybody's familiar with chicken. You take a chicken breast and you're peeling off the skin. You know that opaque thin layer that's a real pain to get off the rest of the chicken? That's what an adhesion is like. It's the closest thing I can explain. But people with adhesive disease have multiple layers of this. And we take an instrument called a Stisler, and it's just these tiny scissors, and we literally cut through the layers a little bit at a time. Dr. Galloway will spend anywhere from 4 to 8 hours in surgery just cutting through adhesions, he and his team, just to be able to get to the intestines to figure out what needs to be done. Post-operative complications, again, always a risk factor, whether, they become septic, they throw clots, a variety of different things that could require them to have to go back. Now, complications of short bowel syndrome. The number one, diarrhea, high output ileostomy. A lot of my patients have one or the other. They either have 10 to 20 bowel movements a day, or they have 2 to 7 liters out of their ostomy a day. So I spend a lot of my time going through, what are you eating? What are you drinking? Trying to figure out if they are following a short bowel diet to help prevent all of this, or at least try and control it as best as possible. A lot of these patients are literally trapped at home because they have to know where the bathroom is. They plan their days around this. A lot of these patients will have bowel movements either in one of two times, early in the morning when they get up or late in the afternoon. That is typically when we see it. With the diarrhea or the high output ileostomy, dehydration. So we're constantly evaluating their TPN formula. Are they getting enough volume in that? Do they need additional IV fluids? Checking their electrolytes. Do we need to add additional electrolytes and IV fluids during the week? Once you're severely dehydrated, nausea and vomiting is going to be the next thing. And a lot of these patients, when they get to that point, they are way behind the ball. Like we needed to have caught up before it got to this point. Unfortunately, one of the side effects with the TPN is hair loss, thinning, and then, of course, the electrolyte abnormalities, hypokalemia, hypomagnesia, and then micronutrient malabsorption. So we do a nutrition panel, usually about every 6 months on these patients. There's about 24 labs we go through and check, checking all the B vitamins, vitamin D, copper, iron. A lot of these people end up with anemia. Then, of course, prolonged use of TPN puts these patients at risk for liver disease. Not everybody can tolerate having TPN for a long period of time, but I do have patients that have been on TPN over 20 years. Chronic kidney disease is another thing over time, especially if they've had a lot of central line infections, and that's the next one, is risk of central line infection. That is usually the number one reason that our short bowel patients end up passing, is they get septic enough times, they can get vegetation on their heart valves. They become so resistant to the antibiotics. Kidneys are damaged in this process, and they end up going into MODS, multi-organ dysfunction. Then another thing that we talk about, and I would bet a lot of people in here might have experienced this at some point, is protein energy malnutrition. I explain this as you feel good, you're sitting here, you got all this energy, you get up and 5 to 10 minutes later, you're like, man, I got to sit down, I'm exhausted. That is protein energy malnutrition. As a country, I don't think we get enough protein in our diet. Fortunately, right now, there are tons of protein-enriched foods and drinks out there. Initially, when I first started doing this job, most of the patients after they had surgery, because it was so important that we get plenty of protein in them after they had surgery, and they'd be like, oh, I don't like the taste of that one. I don't like the taste of this. So I took it personally, and you can ask Carrie, I have tried almost every protein supplement there is out there. I've drank the Juven. I've tried all of it. So that way, when they come through, I'm like, well, tell me what you like. Here's a list, and see what you can find. And a lot of times, if they're willing to work with us, they find something they like. And then, of course, the biggest thing is short bowel patients. Most of ours, we've got about 150, almost 200 that are long-term on TPN for nutrition support. Now, management of the short bowel syndrome patient. Obviously, electrolyte imbalance is one of the biggest things that we work with the nutrition support team. I'm very fortunate, Dr. Galloway and I are, to have such a great team that oversees the management. They work with the infusion companies to make sure that our patients are getting the electrolytes like they need, the adjustment in their formulas, and that's evaluated weekly, bi-weekly, depending. So again, it goes into TPN and IV fluids. Unfortunately, insurance can really dictate your Medicare, Medicaid patients. They can either have fluids or they can have TPN. So then we have to figure out, what we can do, and the max volume that we can have in TPN is 3 liters. So think about somebody who's got 7 liters out of their ostomy, and we can only give them 3 liters of TPN. How do we make up that difference? And if they're not, if the medications that we're providing to try and control it aren't working, a lot of times these people end up back in the hospital just because of the electrolyte abnormalities. Routine labs that we check: CBC, CMP, MAG, FOS, and lipids. We will do supplemental adjustments, like I said, and then the micronutrient analysis. Now, management, the antidiarrheal medications. So we've got the diphenyloxate atropine, also known as Lamodal. I have patients that take 1 to 10 tablets 4 times a day. I will tell them to take them, crush them, put them in a little bit of applesauce, plain, unsweetened applesauce, no sugar, because applesauce has pectin in it. Pectin is a natural thickening. Loperamide, over-the-counter Imodium, same thing. They can do that. So the difference is your diphenyloxate works more on the small bowel. The loperamide works on your colon. You can still use it on the colon, or people without colon, but it just may not be as responsive. One drawback is the diphenyloxate is a controlled medication. It's a category 5. So these patients that are on this, I have to see them every 3 months to do prescriptions. Another one that we like is tincture of opium. Patients by far don't like the taste of it. It does work fairly well. The only drawback is most of our insurance won't cover it, and so it's expensive. For my patients that are really bad, I actually recommend that they buy it and then only use it on the really bad days. So another thing that we use is octreotide. There's short acting and there's long acting. We typically like to add it to the TPN daily, but can do sub-Q injections 3 times a day. Again, insurance kind of dictates a lot of this. We can do long acting. We like to do the long acting for the ones that we can wean off of the octreotide or off the TPN, or they're only on so many days of TPN. They can go to an infusion center and get that done. And the octreotide typically starts out with 100 micrograms, but the max dose is 900 that we will do. We have found that it's very helpful with short bowel syndrome, but it also can help control fistula output, especially people that have very proximal fistulas, meaning that they're higher up in the intestines near the stomach, foregut area. Codeine is another medication that we will use if they are not responsive to the diphenyloxate, the loperamide, can't afford the tincture of opium. Maybe they don't respond as well to the octreotide, or insurance won't cover it. And we've got a handful of patients that do take the codeine. Cholestyramine is a medication that we use, and that is more for our bile acid diarrhea. So when people are saying they're having frequent diarrhea, you kind of delve into it and ask the gross questions. What color is it? Does it burn? You know, does it have a strong odor, like not normal? So in this situation, these patients will have either yellow, orange, green stool that is pure liquid. And yes, if they're having bowel movements, it will burn. Their skin will become very excoriated. So at that point, then you add the cholestyramine, and it's powder. You add it to a little bit of water. I tell most people, most of y'all are probably too young, but when I was a kid, we drank Tang. And it's kind of like that. It's a little chalky, but if they can do it before meals, it's helpful. Some patients only need it maybe once or twice a day. They may not need it before every meal, but it does make a difference if that's what's going on. And then the pancreolipase or Creon pancreatic enzymes, that is another thing. So we start asking, do you see fat in your stool? Is it oily? That way we know we need, before they have meals, before they have snacks, they need to take that to help provide, because their pancreas is not providing enough of the enzymes to break down the fat. Anytime somebody has short bowel syndrome, they're at risk of getting reflux, ulcers. So we always put them on a PPI or an H2 blocker twice a day. So a lot of times what we'll do is we'll have it in their TPN, and then when they're not on the TPN, then they take an oral dose. Now, alternatives. So sometimes they don't respond to the prescription medications, or say you have somebody that doesn't have insurance and they can't afford, medications, can't go get them filled. So then we come up with alternatives from the standpoint of psyllium husk, which is just high dense fiber. They can buy capsules of that at Walmart, Amazon. They can also do Metamucil, what's the other one? Benefiber. And those are things they can add into whatever they're drinking and they don't taste it. Pectin or Certo, those natural thickeners, again, add it to like a little bit of unsweetened applesauce. And the fiber supplements. Konjac root is one that Dr. Galloway likes to recommend when we're getting to a point they've tried all these other things and they're not responding. Bismuth, so like Pepto-Bismol, it works, but the big thing for patients to remember is it will turn your tongue black, can make your stool black. So don't be thinking that, you know, you've got a GI bleed necessarily in this situation. It's the bismuth. And then Dr. Galloway's fresh alternative is fresh deli sauerkraut. I don't think I could ever bring myself to eat that. But apparently it does work. Now, things to avoid when you have short bowel syndrome that will increase the diarrhea. Plain water, it has no electrolytes in it. And people get very confused. They're like, oh, I got my, smart water with fortified with electrolytes. It's not enough electrolytes. It's still water. That's what it really comes down to. Beverages high in sugar. So soda, they got to break up with their Mountain Dew, their Dr. Pepper. Dr. Pepper will cause you to pour out of your ostomy. Trust me. Caffeine is another one. So I will never deny anybody their cup of coffee or their cup of tea in the mornings. And we can figure out a way around that so they get that, but they can't be mainlining coffee all day or soda all day because it will make a big difference. So substitutions, oral hydration powders. For example, Drip Drop is the one that I would prefer because it's got magnesium, potassium, and calcium in it. Liquid IV does not have the magnesium in it. So if they're in a pinch, Liquid IV will work. I have found Drip Drop in Target recently. They also have a sugar-free formula. So for our diabetic patients, that's an alternative. The big thing is they need to follow the directions on there. If it says to add 1 packet to 8 ounces of water, you don't take 1 pack and add it to a liter of water because it's still watered down and you're still going to end up with watery diarrhea. Gatorade, Powerade. There's so many different sports drinks out there. Body Armor Light. Pedialyte's got an adult version now. I have a lot of patients that actually are really liking the adult Pedialyte. That seems to be one that they can tolerate. Dr. Ziegler likes to add a little salt to everything. Most of our patients are not a fan of that, but it does work well. And then the other thing is in the Short Bowel Blue Book, go in there in the back. There are charts that have recipes. And that way they can go in and they can make their own. Say people are like, I can't afford to buy Powerade. Okay, look at this, figure out how to do this. You can do this with table salt at home to make what you need. I will tell you there is a Country Time lemonade one in there that is actually very tasty. So. Complications. So the liver disease, the body rejects the lipids. We'll change them to SMOF. In certain situations, we can do Omegavin. But again, it's an issue of being able to get that approved by insurance. It can be a little costly. Kidney disease is one that is a big problem. Once patients start having kidney disease, trying to manage their electrolytes, their fluid status, when you've got kidneys that may or may not work depending on what's going on, can really make it a challenge. And then the ultimate one is heart failure, because most of our patients, once they get to the point that they're having heart failure, they've already got the kidney disease. And it really is, those are ones that are very difficult to manage on the outpatient setting. And a lot of those are in and out of the hospital at that point. Intestinal failure. So there's a couple of different things. Short bowel itself is intestinal failure because you don't have enough bowel to do what you need to do. The other thing is we have patients that'll eat. They can eat 6 meals a day. They digest it. They don't absorb it. So there's 2 different aspects of when you eat. You break down the food, but your intestines have to absorb the nutrition. And what will happen is these people will eat 6 meals a day. They don't gain any weight. The other thing that we've noticed is we'll have patients that will eat but what they have coming out of their ostomy or when they go to the bathroom is literally undigested food. So then we have to start figuring out, can we add more Creon? Do we need to add cholestyramine? What can we do to try and help them actually digest the food at that point? Because they're not only absorbing it, they're not digesting it. Many of our patients have come to us with intracutaneous fistulas, and that is where you have an opening in your intestine and stool is coming out of your abdomen. And so it is typically when somebody has one of these, it's about a 1-year process for us to get you nutritionally optimized, get you to surgery, take down that fistula, get your body used to the new you with the less amount of bowel, and get you healed. We closely monitored the amount coming out of their fistula because you can pour liters out of a fistula a day. The goal would be less than 200 cc's. Most of our patients come with much higher amounts. What they eat, a lot of these, if it's especially if it's a inferior or into high fistula, meaning it's closer to the stomach, those folks really can't eat or drink anything during that time. And it's hard to tell a patient that, look, you can't eat or drink because it's just going to pour out. Octreotide, again, is a great asset for us if we can get it. Then the frustrating part is the non-compliance. You think about most of these patients have spent hundreds of days in a hospital. They went in, oh, everything's going to be great. We're going to do this one procedure. You should be good. You're going to go home. And it just, there are complications. And so then they feel trapped. They're stuck in the hospital bed. When they get out, they just want to live. They just want to be on their own. And it may be as simple as, I want to drink Dr. Pepper unlimited, and so then you have to explain to them. And they're like, look, I've given up so much. I've given up my job. Some of them lost their homes. I've lost my ability to be able to sit down and eat dinner with my family. Because you think about it from the standpoint, these people, every time they eat, they're in the bathroom and they get a fear of food. Every family situation that we have, we center around a meal. Think about all of our family gatherings. Everybody's bringing something. Think about holidays. And your family's like, here, just have a bite of this. It'll be okay. It creates so much anxiety because they're like, if I eat this, I'm not going to be able to visit with anybody else and I'm going to be in the bathroom the rest of the time. And I feel like crap now. So that's kind of the mindset of where this non-compliance comes from. And you kind of understand. So the goal is to try and work with these patients. I commonly go, what do you want to eat or drink, or what do you want to do that you currently aren't able to do? So once I find out a goal for these people, then I try and work with it. And it may be as simple as, I just want to go to the beach for the weekend with my family. Okay, let's make it happen. When these people come in and they've quit doing their TPN, they're not eating, and we admit them, we have to worry about refeeding syndrome. Their bodies are not used to having nutrition, and it puts them at risk of electrolyte imbalances when we reinitiate TPN. And a lot of times these people end up in the ICU because we're doing frequent electrolyte checks, making adjustments, supplementing, their potassium, their magnesium. And it can take a few days before we can get them optimized. So here's a picture of kind of like a visual of what a fistula looks like. You can see on the outside of the stomach. So basically a piece of bowel has an opening and stools coming out of their stomach instead of going down. Okay. Now the next picture is actually a real fistula. Is anybody in here real queasy? Just, there you go. So this lady came to us. She had had a robotic surgery. She had a history of multiple surgeries in the past, and unfortunately got multiple enterotomies, meaning openings in her intestine. All of those little openings, let me go over here so you can see. So all of these are looks of bowel that were leaking stool. When Dr. Galloway got done, she only had 20 centimeters of bowel left. That is it. We got her closed, we got her healed, we got her ostomy output fairly controlled. It was between 4 and 5 liters. She was on TPN. But unfortunately, she had a stroke about 6 months ago and passed away. Like, we got her all better, and then this happened. So it was kind of sad. Felt really bad for this sweet lady. She had been through a lot. So here's another image. So with these fistulas, we do wound managers on them. We build it up with putty around it to try and protect the surrounding skin. And then this is a wound manager, and I think that one might actually be an Ekin brand. Oh, thank you. Sorry. So as you can see here, we'll do wet gauze in this area. And then up here at the top, that is showing what it looks like underneath and the stool that's kind of coming out. And there's a better picture of that. And the goal with this wound manager is to be able to open this lid and change the gauze out. And hopefully, if we've pouched it and it pouches well, they'll get 3 days out of it. But being realistic, some of these people change these pouches more than once a day. A lot of times they're bedridden because if they get up and move, it's going to leak. So if they have a lot of output, we will actually attach a Foley bag to it to drain it. We have a lot of patients that'll come in and we'll find out they've been home and they don't sleep, they're exhausted. They're up every hour emptying their pouch. And just something as simple as going and getting a Foley bag and attaching it. And they cry and they're like, I don't have to get up every hour. I can sleep, just to be able to get them that amount of rest. So surgical options for short bowel syndrome, small bowel transplant. The centers that we have referred to is Georgetown. Duke has one, Miami. There are plenty others across Cleveland Clinic as well. And then for us, Dr. Galloway does the serial transverse interplasty or STEP procedure. So the STEP procedure came about in the early 80s, and it was actually started on children. The babies that were born with necrotizing enterocolitis, meaning that their bowels get kinked off and they lose significant amounts of their intestines and they become short bowel. Over 2 to 3 years, your body adapts to that new amount of bowel. And what happens is over time, the diameter of the small bowel, instead of being about this big, opens up to be about this big. And you can do an MRI and be able to see where they've had small bowel adaptation during that time. And we measure it. And once it gets to a certain size, then we know these patients potentially are a candidate for the STEP procedure. Now, you may have huge sections of the small bowel that adapt, or you may have just like one section and then there's another section that didn't adapt at all. What'll happen is Dr. Galloway goes in, and I ask people, and again, most of y'all may not know, who knows about paper dolls? It's okay. So back when we were kids, a long time ago before the internet, we would take paper and we would fold it accordion style, and you would cut on the sides to make out a paper doll, and then you would stretch it out. So with the STEP procedure, we take those big pieces of bowel, and he goes in on one side and cuts and clips and sutures all and cauterizes at the same time, then goes up a little bit higher, cuts on the same side, and it makes a zigzagged, but it stretches out. So we can take somebody with like 50 centimeters of small bowel, and if they've adapted really well, we can almost double the amount of small bowel that they have. So taking somebody from 50 centimeters to 100 might make it to that they could just have TPN and they don't have to have supplemental IV fluids and electrolytes. If they've got 100 and we take them up to like 150, then depending on if they've got colon present or not, we might be able to actually wean them down on the number of days of TPN. We have some patients that we were able to completely successfully wean off of TPN. They need IV fluids every so often, especially during the summer. So the adaptation, again, like I was talking about, takes about 2 to 3 years. Another thing that we can use is the human growth hormone or teglutide. And those, what they do is on the inside of the small bowel, there are these little finger-like things. They're called cilia. And with that medication, it increases the blood flow and growth of it. And so what happens is those cilia get bigger. That increases the surface area for nutrition to be absorbed into the bloodstream. And so what will happen is we start patients on this medication and they'll tell me that they notice that they're not putting out as much stool out of their ostomy, or they're not having as many bowel movements, or more importantly, they'll be like, it's starting to get thicker, because short bowel patients, they're not going to have formed stools. They're going to have diarrhea. The goal is to make it mushy, if we can do that, and to control the amount that comes out. So with that medication, some people respond better than others. I've had some that were putting out 7 liters out of their ostomy. They started the medication. 2 weeks later, they were gaining weight, and we were able to wean them off the TPN. Some people have intestinal cramping and can't tolerate it every day, so they have to go to half a dose or every other day just because the pain is too intense. So we just kind of have to work with them. This is an area that Dr. Ziegler specializes in. We send a lot of our patients to him to help manage this. Epidermal growth factor is another one that's still undergoing studies. But the number one thing is having our patients follow the short bowel diet. That book, if they can make that their Bible, it is not a hard read. It's very well written. And I will tell you, the patients that follow that, they recover and do much better. Now, provider resources for short bowel syndrome management, evidence-based journal articles. There are a lot of things out there, okay? The Short Bowel Foundation is an excellent resource for patients. They have chat groups, support groups. There's a lot of wealth of information. Aspen, the American Society for Parenteral and Enteral Nutrition, great resource. They have lots of articles. They have a lot of webinars. There's a lot of information to help people. Then the Lift Echo, which is the Learn Intestinal Failure Teleco. Now, today's questions. Let's see. What happens when patients do not take their anti-motility medications? A, no change in bowel pattern. B, increased stool output but no change in consistency. C, increased stool output and changes to loose liquid diarrhea. Or D, constipation. Very good. And that is the one thing that's hard for a lot of patients to understand. And this goes across everything: diabetes, hypertension, any of it. Well, I took the medication. It fixed the problem. I don't need to take it anymore. It's not an allergy medicine. It's not like you take a Claritin on the days when the pollen's out. This is a medication that you will have to take for the rest of your life. And that is, helping them learn that is the hard part. It's like saying that, well, I don't have diarrhea. Well, you don't, because you're taking the medication to help control it. It's like diabetes. I don't have diabetes. Well, yeah, you do. You're just taking medication to help control it. So, number 2, what liquids do people with short bowel need to avoid drinking? They can drink whatever they want, avoid plain water, avoid soda, or D, B and C. And then finally, this one's probably the hardest one. What electrolytes require close monitoring in the short bowel patient? Sodium and chloride, magnesium and potassium, magnesium, potassium, and calcium, calcium, chloride, and bicarbonate. C. Those are your 3 ones. The reason is magnesium, potassium, and calcium, when they get off, they can affect 2 things. They can affect your heart, the electrical impulse in your heart, and they also can cause muscle spasms, Charlie horses, that are the worst that anybody's ever had. And a lot of times we'll know that our patients are having electrolyte abnormalities because they'll call and they go, my hands keep cramping. or I keep having to wake up in the night because my feet keep cramping. And that's how you know that you need to check a CMP and see what's going on. And then here are all of my references. Questions? In case somebody wants to ask something.
Question. What do you see as the hardest part in patient, like when they're in the hospital for the nurses and all that kind of stuff on education? Can you repeat it, or do we watch out for the patients on the inpatient side?
Okay, so the question is, what is the most challenging thing when patients are in the hospital with taking care of the patients and nurses maybe not necessarily understanding the process for this? I will say that since COVID, the turnover of nursing has been significant, but I think that's been significant in all areas of healthcare, unfortunately. Short bowel syndrome is not something that is taught in school. It's not even in our nursing med-surg classes. So you've got to kind of understand all of that. I think being able to get the nurses together and answer the questions, but then you get float nurses, everybody. You know, it used to be a long time ago. Again, this was when I started years ago. We were told to do 2 years of med-surg. Once you did 2 years of med-surg, you could go to another area. Now, people go into what they're interested in. So you could still get floated to a med-surg unit and not really understand. And most of the time, yeah, they're drinking buckets of water and a 2 liter of Dr. Pepper. And that can be a challenge. Or they'll go to rehab and they're on TPN and they're trying to eat because they want to. And they're told, well, if you eat or drink, it makes you have a lot of stool out of your ostomy and then we have to clean you up. Can you just not? These are all things that I hear in clinic, and it's an education thing. So that's one reason why I wrote this and try to, you know, there's an old saying that fish for a man, he eats for a day. Teach a man to fish, he eats for a lifetime. So this is me teaching a man to fish. If I can teach everybody about short bowel, how the average person, what they need to do to manage it for a better life and better quality of life, then I've done my part. Okay.
Hey, I have a question. In terms of using the octreotide, do you find that how long do you typically use it for? Because isn't there some issues with long-term use causing problems with cholestasis and things like that as well? And
So,
what's your typical usage time?
yeah, unfortunately, these people are at a point that they have to have it. Like, that's the only way we can get you out of the hospital.
Mm-hmm.
If they go home and they quit taking it, they end up back in the hospital, severely dehydrated, electrolyte abnormalities. You have to weigh, you know, what's better for the patient. I mean, we would also say that long-term TPN isn't good for a patient, but these people, they can't live without this. So, you know, it's learning to manage it, and then over the next 2 to 3 years, see how they adapt, see if we can wean them off of it. Again, you know, step procedure, the growth hormones, those are promising areas to kind of help. But, you know, these people, most of them are older and just, we're doing what we can to give them what time they have left or to be able to manage long-term.
Do you find that the long-acting octreotide is as effective as like adding the other to the TPN?
I think it depends on the anatomy of the patient. Our really short bowel patients that don't have an ileocecal valve and don't have colon respond better to the octreotide and the TPN. People that have a little bit more bowel and we're going to be able to get them weaned off of the TPN or weaned down, long-acting works better for them.
Jamie, we have a question online from a person, and it says, it's kind of a two-part, but what is the title of the Blue Book? And second part is, do you ever see patients with a partial gastrectomy and or fundoplication who have similar symptoms of short bowel syndrome, like diarrhea, cramps, dehydration due to lack of pancreatic enzymes?
Okay, so the first one is the Adult Patient's Guide to Managing a Short Bowel. And it's currently the 5th edition. Carol Parrish is the one who wrote that book. And then repeat the second question.
Okay, so um, do you ever have patients with a partial gastrectomy and or fundoplication who have similar symptoms of short bowel syndrome, such as diarrhea, cramps, dehydration, due to lack of pancreatic enzymes?
Yes. And we will put them on Creon. You do stool studies, you do labs. Again, go through asking all the questions of what their stools look like, when they're having the symptoms. A lot of times I'll have people keep a food and bowel movement log for me. And I tell them, you can go over a period of time and learn, hey, if I eat that, I'm in the bathroom. So that way you can learn kind of what's causing it. But yeah, we have several patients that have true intestinal failure, meaning they're not short bowel. They have all their intestines, they don't work. They just don't work. And so these people will end up on TPN. They'll end up with a G tube to drain and a J tube to try and put meds through. Sometimes we can get them on enteral feeding and get them weaned off the TPN. And in some of these cases, Dr. Galloway will go in and completely remove the stomach, do a complete gastrectomy, and have a J tube for meds and feeding. It's just kind of depends. Most of these people are young females. And I saw this when I was in trauma and didn't make the connection. You would have people that would have a seatbelt bruise, nothing major like in a car accident, and all of a sudden post, 48 hours, they can't keep anything down. They can't eat. They don't want to eat. Their bowels quit working. And we end up having to put them on TPN for a while. And we never really understood it. And then you start delving into when they were kids. Did you have problems eating? Mom, what did they have problems? They were picky. Did they have chronic constipation as a child? These are all the things we start looking, their connections for this form of intestinal failure.
Thank you, Jamie. And we have another question online. Do patients with short bowel syndrome receive behavioral therapy to adjust to their new life with short bowel syndrome? So some kind of behavioral therapy or support? in
So
that?
Carrie Kruger is our outpatient social worker. And we are so blessed to have her. When I started, we did not have her. It took me 2 years to collect the data to prove that we needed an outpatient social worker. Thanks to her coming, I'm able to get people not having to be readmitted to the hospital quite frequently because a loss of services, whatever, we need to change something around. But another aspect that she has brought to the table is she will actually meet with these patients and kind of talk to them because it is a process. Once you get through the physical part of, say, you've went through the surgeries and you're recovering, a lot of these patients become very tearful because their life is nothing like it used to be. And they think, oh, I might now be at a point where I can make it. So we talk to them that your body healed. Now your mind has to heal. Your mind has to get used to the new you as well. And Carrie will provide them with outpatient resources. We also tell them that, like the Short Bowel Foundation, there are lots of online groups for them to join for support.
Oh, and to clarify, another comment on that same question is behavioral mental health therapy,
Yes.
not just behavioral, but mental health.
Right.
I think you.
Right. The one challenging part is, think about it from the standpoints, most of your mental health medications have to be absorbed. And
It's a problem.
that is the real challenge. We will have people that will go and get ketamine infusions, electric shock therapy. They have to do something kind of an alternative because if it's a extended release medication, they may not absorb that. And there's several of your SSRIs that are that way. Okay.
I was just going to add to that a little bit on the mental health piece. It's finding, one of the things we try to do is some of these patients, are on chronic pain. So sending mental health for, sometimes they have to go to the pain addiction specialists who also have a component of mental health with that, and chronic, conditions and that type of stuff to address, the mental health piece and that type of thing. With our clinic, I'll meet with the patients too. And for the first question, if anybody is interested in getting a free copy of the #7 book, which is a guide to the short bowel syndrome book, you can apply, because I did this, on shortbowelsyndrome.com. And you can sign up for their website, and you can also click to request a one-time copy of the book. And you can also provide that to your patients as well, and they'll send it to them.
Okay, we have another question.
Thank you. And about 7 more minutes.
My question is, you give protein, nutrients, everything. Has anyone looked at anti-inflammatory compounds in these individuals since they have an inflammatory issue with their bowel? I'm not talking about the really, really short, but others, such as, I'm assuming they don't eat foods that have the natural polyphenols and other things that are known to help with the bowel. Has anyone ever looked at, because I don't see it in the literature, so I just know if anyone looks at, is that as supplemental?
So one thing specifically, we try and encourage our patients to drink the Juven because it's got a lot of the protein nutrients in it that helps repair the inside lining of the small bowel. I know that there's some studies coming out looking at the anti-inflammatory from an inpatient standpoint. We will look at CRPs, but that is more an inflammatory response to infection. You can see some inflammation on bowels on CT scans. We do look more on MRIs, and it's definitely something more for like our Crohn's patients, our IBD patients are the ones we look at more closely from that standpoint.
I'm just thinking from the standpoint of, we know these compounds like upregulate or downregulate genes that are associated with inflammation and also, responses to inflammation. And I just think it's an area that we just don't provide, and we
Right.
tell everybody else, and precision nutrition, and it's so important. And this seems to be like a group that, could really benefit from it.
No, I agree.
And the other question I have is Benefiber, do they take the Benefiber gummies or do they take the straight Benefiber?
They could do whichever works for them. Personally, I find that the psyllium husk capsules work better because it's a denser form of fiber. So the difference is for us, if we take fiber, it helps us have bowel movements. People with short bowel, it actually thickens up their stool. So, and I have found that the denser form works better.
The reason I was asking is because there's inulin in Benefiber gummies, and I didn't know if any of your patients had, like, it could send me to the moon inulin, so I didn't know if they had problems with inulin.
I don't know.
I have one more question. So, in the same vein that we don't always learn a whole lot about short bowel syndrome in school, I always find too that even those of us that have maybe had a patient or two or a few patients of this, people are very unfamiliar with the impact of having or not having the ileocecal valve. Could you expand a little bit on what you might see in someone who does not versus does?
Yes, definitely. So whether they've got their colon in place or not having the ileocecal valve, they will have more urgent frequent bowel movements, or output from their ostomy will be more from the standpoint, like I said, I tell patients it's like a doorway because the whole point is that it's controlled going into the colon. If there's no ileocecal valve, things will go through you much quicker. And if they're drinking water, it's really going to go through them much quicker. A lot of my patients will eat and then they drink later. They have learned if you've got short bowel syndrome or if you don't have an ileocecal valve, you eat first then you drink your liquids later, because if not, it literally just flushes it through. Okay.
Can I just comment one more thing? When you're taking the timing of the medications, the antidiarrheal medications is also a big component, you know,
Yes.
just like you mentioned about the Creon, but you should also take the Lamodal and the Imodium, like before you eat, to try to get that into your system to help slow things down.
Yep.
Because if you try it after the fact,
It doesn't work.
the
Yes,
horse is already down the road.
30 minutes before meals and at bedtime. Yes.
We have no questions, no other questions online. Um,
Thank you. Thank you so much.
Thank you, Jamie, Dr. Dickey, for that wonderful presentation.